Welcome to another 6-pattern video. My name is Kevin.
My name is Max.
And we're going to look at a lung biopsy today.
Straightforward case, right? Lung biopsy.
I'm not sure there are any straightforward surgical lung biopsy cases.
Said no one ever.
Right.
A straightforward surgical lung biopsy. So this case comes from a 61-year-old female. She was actually really healthy. Perfectly healthy 61-year-old. Maybe a little bit of hypertension, no diabetes or anything. But over the course of 1 week, she went from perfectly healthy to profoundly short of breath.
Oh.
Bilateral infiltrates. She went from playing with her grandkids to in the ICU on a ventilator.
Wow. So that's the classic acute clinical presentation. And I think you can imagine this being a terrifying experience for the intensivist or pulmonologist who's involved in this case, because now they're in the limelight for trying to figure out what's going on here. And
exactly.
The patient is almost dying in front of their very eyes.
And indeed, the patient was too sick to undergo surgical lung biopsy at the time of that presentation. So they treated her empirically, high-dose steroids, as all patients who present with clinical ARDS get.
And antibiotics, just to cover the broad spectrum.
Right. They treated her empirically, and she was one of the ones that made it through the initial event and made it about 3 weeks into her hospitalization. She was actually slowly recovering, got off of the ventilator, got transferred to the floor. But after she got transferred to the floor, all of a sudden she started having increasing shortness of breath.
Wow.
So they wondered, is this a recurrent flare? What's going on? And so at that point now, about 4 weeks into her presentation, they took her back to lung biopsy.
We don't know whether she was still on steroid, do we?
I think she was. I think she had finished her taper, but she had gotten a lot of steroids.
Right.
So this is a perfect presentation for the pathologist, right?
Yeah.
The disease process has been going on for a month. The patient's been treated, so that's going to modulate what's going on in this biopsy. So how in the world are we going to approach this?
Well, especially since we're standing right at the center of this process now, because for the clinician, if this is a recurrence of whatever gave her initial DAD, they're going to want to restart high-dose steroid.
Exactly.
If this is a consequence of high-dose steroid,
they're not going to want to.
They're not going to want. They want to
steroids.
treat infection if that indeed is the problem.
Exactly.
So they're going to really be looking at us when this biopsy comes out. They're going to call you in for a frozen section, saying, "We really need to know tonight
what is going on.
What is going on here? What direction should we go?" So it's all up to you guys.
Now, I'm kind of a simple person, and when I look at this biopsy, the first thing I'm going to say is this looks like NSIP.
Yeah, I mean, those look kind of like alveolar walls at low magnification, but they're like 10 times too thick.
Way too thick.
And they're all involved in this field. I mean, some of them a little less involved in the bottom right corner, but that thick confluence of alveolar walls into this kind of pattern, at low mag, it's an NSIP look.
Right. And so what would the pulmonologist say if we just signed this out as NSIP?
Send it out. The whole reason we're making these videos is we're trying to help you navigate these cases so that the first thing the pulmonologist says to you is not send that case to Max Smith at Mayo Clinic. What we want them to say is, thank you for your input. Which direction do you think we should go? And then you help them if you can. And if you can't, maybe it will still have to be sent out. But let's get through that first phase by you giving a cogent, intelligent response to this pattern.
And it's about putting together a story
Right.
that fits with the way the patient's presented and with what you're seeing under the microscope.
Right.
Now, you don't see it in all the textbooks or the literature or anything, but actually an organizing DAD looks a heck of a lot like an NSIP pattern.
Because in the late phase of DAD, that organization goes into the interstitium, collagen starts getting deposited, and over time, presumably some patients will resolve that and go back to near normal lung function after surviving.
And some patients
areas.
won't.
And some won't.
Some patients might heal with a fibrotic NSIP pattern, which is one of the things to think about when you have a fibrotic NSIP pattern.
It's a little short, right? Her time interval of 4 weeks is a little short for bone.
Yeah.
So I'm seeing some bone here. That makes me think that maybe this biopsy is the tip of an iceberg. We haven't seen the whole
something
thing.
else going.
She might have had something that she was asymptomatic, and she's now flared. But the second flare is what we have to pay attention to right at this moment.
Right.
So what are we going to do?
So why was the patient biopsy? So we have what looks like an organizing DAD process.
Right.
And what's notably absent here as we look through is there's not a lot in the way of residual hyaline membranes.
Right.
In fact, I don't see any residual hyaline membranes
Right.
here. There's some mucostasis and debris in the airways and that type of thing.
So what if you sign this out as organizing DAD?
It still wouldn't explain the process.
Why she
right?
flared.
It wouldn't fit with the story of how the patient has presented.
Right.
So we have to look at this biopsy with a critical eye to see what in the world, what else is going on in this biopsy.
Wow, look at that. There is some normal lung in here.
Yeah, just a little bit of normal lung here with sort of thin, delicate alveolar walls. So,
Curiouser and curiouser.
right. So from low power, there's this little area right here that kind of caught my eye when I was looking at this case.
Yeah, some
And,
nodularity.
and it's pretty subtle, right? But it is a little bit nodular, and it kind of looks red, like there's some hemorrhage there.
Right.
So I think that area there really kind of catches your eye.
Right.
And if we go to higher power here, and we see exactly what's going on, it looks like we have a vessel here. It's pretty inflamed.
Yeah.
Maybe she has a vasculitis now.
Wow, strange. And a vessel that size with acute changes, to me, always raises the specter of infection.
Exactly. In fact, this is more likely infection
Than vasculitis.
than it is vasculitis.
And I think there's necrosis. There's a focus of necrosis right there. That smudgy looking material, the kind of a bluish tinge.
Necrosis and this karyorectic debris. Right?
Wow.
We call that the dirty necrosis that you see. And anytime you see this type of necrosis, there's sort of necrotic material, fibrin, all this karyorectic debris, what do you think about first?
Infection.
Infection, and particularly viral infection.
Right. Infarction, if there was a bigger area, and the weird case where they actually biopsy a lung infarct can have that dirty look too. So we put it in the differential diagnosis, but in truth, this kind of microscopic area of necrosis, especially around an airway. Because the airways generally are dirty, right? So they're connected to the outside.
Right.
So we have to think of them as being a fomite, if you will, for where infection might take a foothold. What do we have there?
So you wonder about some of this, right?
Yeah.
We've got this dirty necrosis in the background. We've got acute inflammation in vessels. And so we're wondering about a viral infection. So you wonder, could any of this be viral inclusion? Wow. And it's really hard, I think, really, to say anything definitive here that we say, yes, this is absolutely
Smudge
virus.
cells of the virus.
But I'll tell you what, it's concerning enough, I think, to get some immunohistochemical stains.
So what would you do?
So I'd probably do CMV, I'd do HSV, and I'd do adenovirus staining.
Right.
I think those are the three big ones to consider in this setting.
Yeah, I mean, that's from a theoretical standpoint. I think in this context, centered on the airway, in this immunocompromised host, I think we got to be thinking about the CMV and herpes virus.
Yeah. And I'd probably throw a GMS on there too.
Yeah, absolutely.
Because remember, this lady was profoundly immunosuppressed from high-dose steroids,
Right.
a gram of solumedrol a day,
Right.
for a period of time as she got through her DAD process.
Right.
So sure enough, immunohistochemical stains shows positive HSV within this epithelium here, and within some of these areas of necrotic cells over here, the pneumocytes. And we saw that this is centered around airways. So what she has is a component of herpes virus pneumonitis.
Complicating a background picture of organizing diffuse alveolar damage, simulating so-called fibrosing, organizing pneumonia of immunologic origin. So in the end, we don't really know what her presentation was related to.
True.
Because it probably wasn't related to the virus that we have now.
No,
this is a
secondary.
new pathogen.
This is why she's now short of breath again.
Yeah.
And it's iatrogenic.
Yeah.
It's related to her steroid therapy, which was required to save her life.
Right. So she was treated, and she got better.
So it's and this makes a perfect story for the pulmonologist, right? Oh, yeah. In the background, you see organizing DAD. We thought we'd see that. Oh, you see herpes virus pneumonitis.
We thought there was something new.
That explains her new changes.
Right.
So when your story matches up with what the pulmonologist is seeing clinically, then everything fits together real nicely.
Yep. Great. Don't forget to comment below and like us if you do, and we'll see you next time.